Morning, esteemed guests, speakers, panelists, and everyone joining us from different locations. Welcome to day 2 of the 2024 PSHAN Annual Conference. My name is Clifford Edomiade. I'm the Head of Corporate Communications at the Private Sector Health Alliance of Nigeria, and I'll be your host for today's conference. Our theme for the conference is harnessing private sector solutions for universal health coverage in Nigeria's ever evolving health insurance landscape. To kickstart today's conference, I would like you to join me to welcome the MD CEO, Private Sector Health Alliance of Nigeria, in person of Dr. Tinúọlá Akínbọ́lágbé for the welcome address.
Good morning, distinguished guests, esteemed speakers, panelists, and to all our participants joining us today. My name is Tinúọlá Akínbọ́lágbé. I'm the MD CEO at the Private Sector Health Alliance of Nigeria, PSHAN, and it is my distinct pleasure to welcome you to day 2 of the 2024 PSHAN Annual Conference. Our theme, harnessing private sector solutions for universal health coverage in Nigeria's evolving health insurance landscape, continues to guide our discussions today as we delve deeper into critical health issues facing our nation. So I will start with a recap of day 1, which held on Tuesday, the 25th of June, and it marked an exciting start to our conference. We had insightful presentations and robust discussions. The day started with a goodwill message from Dr. Jide Idris, the Director General and CEO of the Nigeria Center for Disease Control and Prevention, NCDC, who, despite his spearheading the nation's response to the ongoing cholera outbreak, shared a message emphasizing the importance of our collective efforts towards achieving universal health coverage, UHC, in Nigeria. The keynote presentation was delivered by Dr. Tayo Adeloju. He is the CEO of the Nigerian Economic Summit Group, NESG. Dr. Adeloju provided an extensive analysis of how the private sector can be a driving force for universal health coverage in Nigeria. He highlighted the need for innovation, investment, and collaboration, underscoring the significant role that private enterprise must play in the healthcare sector. We will revisit the keynote presentation from Tuesday by Dr. Tayo Adeloju, which will be played later in this session, as these insights lay a very strong foundation for our conference theme. We were also privileged to hear from Nicole Speaker. She's the Global CEO at Farm Access Foundation, and she delivered the special guest address on leveraging digital technology and the private sector to achieve universal health coverage. Her presentation offered a comprehensive look at global innovations and local applications in Nigeria, and helped to compare our health sector to other African nations, thus reinforcing the necessity for digital transformation in healthcare. Our deepest appreciation goes to the esteemed PSHAN Board of Directors, our board chairman, Mr. Jim Ovia, Mr. Aigboje Aigemokwede, and Mrs. Omobolanle Victor Lanio, who, despite their very busy schedules, were in attendance on Tuesday. Our other board directors were duly represented as well. We thank them for their unwavering support and their guidance at PSHAN. The panel session on day 1 was particularly invigorating. Our distinguished panelists shared their perspectives on the supply facet of achieving UHC through health insurance, using health insurance as a tool in Nigeria. Central to the panel conversations were discussions around the challenges, the very real challenges that we face, and the opportunities and possibilities that are presented by the Nigeria Health Insurance Act of 2022, NHIA. This dialogue provided valuable insights into operational efficiencies, regulatory hurdles, and innovative funding models, which are necessary for the successful implementation of health insurance schemes. As we look forward to day 2 today, we will be shifting our focus to the demand facet of achieving UHC through health insurance in Nigeria. We will explore strategies to ensure inclusion for the most vulnerable populations. discussing how the private sector can actively contribute to expanding health insurance coverage to underserved communities and marginalized groups as outlined in the Nigerian Health Insurance Act. For our keynote presentation today, we are honored to have Dr. Leke Oshunoyi. He is the chairman of the Health and Managed Care Association of Nigeria, HIMCAN. His extensive experience and expertise will provide insights in his keynote address. Dr. Oshunoyi is a seasoned private medical practitioner and health administrator with a distinguished career spanning several decades. He is the managing director at ICO Multishield Limited and has served in various leadership roles, including at the AGPNPN, which is the umbrella body for general and private medical practitioners in Nigeria. His wealth of experience and dedication to healthcare management will undoubtedly enrich our discussion today. So our panel discussions today will feature subject matter experts who will analyze critical factors affecting the uptake of health insurance amongst vulnerable populations. Our distinguished panelists include Dr. Emanuela Zamba. She is the Permanent Secretary and the CEO at the Lagos State Health Management Agency, LASHMA. She's here represented by Mr. Olatunji Rotimi, who's the Head of Business Development at LASHMA. We also have Mrs. Vivian Ihekiazu. She's the Managing Director at Nigeria Health Watch. Mr. Ikechukwu Ofuani. He's the Director of Worldwide Government Affairs and Policy for West and Central Africa at Johnson & Johnson. Also here we have Dr. Oluwakolade Abayomi. He's a Group Medical Consultant at Dangote Industries Limited. Mr. Kenneth Okolie, the CEO at Synlab Nigeria, and Dr. Maurice Atoki, CEO at the African Business Coalition for Health, ABC Health. Our esteemed panelists will discuss the challenges and strategies for increasing health insurance coverage amongst underserved populations, exploring how the private sector can innovate and collaborate to overcome barriers such as affordability, accessibility, and cultural perceptions. These discussions aim to develop actionable recommendations that will help to promote sustainable progress towards achieving UHC and ensuring healthcare inclusivity for all Nigerians. In conclusion, as we kick off on day 2, I encourage you to actively participate, noting any comments or questions that you have so that you can share that with the compare during the panel sessions. I thank you once again for joining us. We look forward to a day of productive discussions and meaningful outcomes. Thank you.
Thank you very much, Dr. Tinola Akinbolade, the MD CEO of Private Sector Alliance of Nigeria. Next, we'll have a goodwill message from Dr. Ebere Anyachukwu, the Health Advisor, UK Foreign Commonwealth and Development Office, British High Commission. Sir, you have the floor. Thank you.
Yeah, good morning. Good morning, ladies and gentlemen. Can you hear me?
Yes, we can hear you, Dr. Ayachiku. Good to have you here.
Yeah, great to be here. Excellent. So, so my name is Dr. Ebere Ayachiku. I'm the Health Advisor at the UK Foreign Commonwealth and Development Office in Nigeria. And I'm really delighted to join you today at this virtual conference of the Private Sector Health Alliance of Nigeria. As the nation with the highest number of preventable deaths of mothers and children in the world, Nigeria faces an enormous challenge. The country must rapidly scale up coverage, access, and uptake of life-saving health and other essential services, particularly among the poorest and the most vulnerable segments of our population. And that's why the theme of this conference, Harnessing Private Sector Solutions for UHC in Nigeria's evolving health insurance landscape, is so important. Private sector has a critical role to play in Nigeria's efforts to attain universal health coverage. According to the 2018 Nigeria Demographic and Health Survey, more than 50% of Nigerian children who received advice or treatment for pneumonia or diarrhea received it from the private sector. It's clear that Nigeria cannot rapidly attain universal health coverage without harnessing the private sector optimally. Now, that said, there are a number of serious constraints to harnessing Nigeria's private sector to contribute optimally to public health objectives. And these include the lack of an effective and large-scale health financing system that ensures care free at the point of use to most of the population. Also includes poor regulation, stewardship, inadequate access to finance, and the fragmented structure of private health provision. And the Nigerian government has taken commendable steps towards attaining UHC by launching the Health Sector Renewal Program and the Compact to improve population outcomes at scale through a sector-wide approach. Now, scaling up health insurance coverage through the Basic Healthcare Provision Fund and the Vulnerable Group Fund is a key part of this approach, and we hope that this will reach the majority of Nigeria's population. Now, scaled up health insurance offers exciting opportunities to better harness the private sector. Private providers can be empaneled to provide services to the vulnerable population with health insurance, particularly in areas that are poorly served by public providers. Empaneled private providers can also enable the government to more rapidly achieve its goal of doubling the number of primary health facilities supported by the Basic Healthcare Provision Fund. And a number of states, as we know, have successfully established public-private partnerships with private providers to take over and manage primary and secondary health facilities. But the contribution of the private sector isn't just about health service provision. Regular funding from the BHCPF and the VGF to health facilities will enable the system benefit from efficient and innovative private sector providers of financing, medical equipment and maintenance, reliable power and water supplies, laboratory services, drug and consumable supplies, and information systems. Now, for example, if a primary healthcare facility, for instance, gets regular funding from the BHCPF, what that means is that rather than the government having to incur huge capital expenditure to, for instance, put solar power in that facility, rather you could contract a private provider that can provide that solar power, make the capital investment, but then the facility pays from, is able to pay the actual cost of the power from its BHCPF income, and leave all the maintenance and all the other issues to the private sector, who can probably do that a lot more efficiently. Now, leveraging these private sector providers will save government significant capital investment costs required and enable much faster progress towards universal health coverage. And we hope that the discussions at this conference will lead to actionable solutions to help harness the contribution of Nigeria's private sector towards universal health coverage. Ladies and gentlemen, a healthier future for Nigeria's people is within reach. Together, we can make it happen. Thank you.
Thank you very much, Dr. Anya, for that insightful goodwill message. Now we'll have a presentation from ADHFP. And ADHFP is Adopt a Healthcare Facility Program. It's PSHAN's flagship initiative. And to give the presentation today would be Rukayat Sadiq, who is the team lead, ADHFP.
Thank you very much, Clifford. Good morning, everybody. Good morning, distinguished ladies and gentlemen. Permit me to stand on existing protocols. My name is Rukayat, and I'm here to share the gospel of the Adopted Healthcare Facility Program, the ADHFP. The ADHFP is a flagship program of PSHAN, and I'll be giving an overview of what we do at the ADHFP and how we intend to improve the quality of healthcare, especially at the grassroots in Nigeria. Next slide, please. Next slide, thank you. So the ADHFP is a program that was designed to improve the quality of healthcare in the communities as at the primary healthcare level. We know a large number of Nigerians still live in rural and suburban areas, and that accounts for need for more healthcare, especially at the grassroots. According to some recent statistics, it has been shown that about 70% of the primary healthcare centers we have in Nigeria are not able to provide optimal services. So this was where the ADHFP was came into being, to be able to provide for these primary healthcare centers to enable that they are able to provide optimal services to the people at the grassroots. So the ADHFP is actually a very unique program, unlike some other health interventions at the primary healthcare level, because for the ADHFP, we intend to provide services at every single point at the primary healthcare level. We're talking about HR, that's the staffing. We're talking about provision equipment, provision of sustainable form of financing for these PHCs, and then the community surrounding these PHCs. So for us at the ADHFP, it's our aim is to establish one standard primary health center in every local government in Nigeria. That's coming to a total of 774 local government area. So the ADHFP is what I would describe as a program for the people and by the people. The program of the people, by the people, and for the people. What do I mean by that? The ADHFP, for the ADHFP, we have people that we call adopters. Adopters are individuals, private organizations, and corporate bodies that can come together as individuals to invest in these PHCs. And then when they do that, they take over the operations of these PHCs for a period of 5 years. We also do not do it alone. We do it with the community, we do it with the local government, and we do it with the state primary healthcare development agencies in that state. So we started out in some states, and we are currently in Delta State, Bauchi State, Rivers State, and Edo State. We intend to expand to other states in coming years. Please, next slide. So the ADHFP approach is actually quite simple and straightforward. What we do is we do an initial assessment of these PHCs. Once the assessment is done and there's a need for the revitalization of these PHCs, we engage the host community, not just the community. Our engagement starts from the federal level down to the local government level, and even down to the immediate community where the PHC is. Then we do a lot of stakeholder engagements, liaise with the regular agencies, both at the federal and state level. Then we begin our revitalization process. And then when we're done with the revitalization process, we transfer back to the community. And that was why I said the ADHFP is a program by the people and eventually for the people, because we transfer back to the community to continue running this program. We stay for a period of 5 years to make sure that things are done well. And then after 5 years, it is eventually transferred to the community. Next slide. So this is our coverage map. We actually we have some organizations and individuals who have actually adopted PHCs. For Kano State, we have 44 PHCs adopted by the Aliko Dangote Foundation. For Rivers State, we have 25 PHCs already adopted by the Howe Foundation. In Delta State, we have 25 PHCs already adopted by the Jimovia Foundation. And in Edo State, we have 23 PHCs adopted by the Agimokwede Foundation. We also have 3 PHCs adopted by independent adopters. We have one from the Chigari Foundation, one from Ms. Yusufu. And then we also have, with our collaboration with the MTN Foundation, under What Can We Do Together project, they've also adopted 52 PHCs all across the nation. So for our pilot project, we started with our pilot in year 2021, where we started with one PhD in Bauchi State and another one in Delta State. The PhD in Bauchi State, Jumberry PhD, it's in a very small remote community, a Madara community in Katagum local government of Bauchi State. So I don't know, the picture is quite small, but on the left-hand corner, we have the facility, what it looked like before renovation. The facility was actually not even in use because it was really dilapidated. Then after we went through all the processes, we completed renovation. They have staff, there's water supply, there's electricity, there's infrastructure, and then the facility is running very well. And this has tremendously improved the data coming out from this facility in terms of service provision. Next slide, please. Then for the South, we chose Delta State, Boji-Boji-Agbo. Please go back to the previous slide. Thank you. We chose Boji-Boji-Agbo community in Ika South local government of Delta State. And then we picked this model PhD in Boji-Boji-Agbo. Similar story to what we had in Bauchi. The facility was, although this facility was in use, but not at optimal use, we innovated, supported the facility, and this is what we currently have now. And I can tell you that this has greatly improved service provision in this facility. Please, next slide. Okay, so stakeholder engagement forms a core of what we do in the ADHFP. We realize that for us to strengthen our activities at every point, we have to improve stakeholder engagement and then keep liaising with the government at the state, federal, and even the communities involved. And then because of that, we have health management committees formed at the local government level to monitor the day-to-day activities of these PHCs. Please, next slide. Next slide. So this was when we had our MOA signing in Edo State. Please, next slide. No, the previous slide. So yes, I mentioned about our collaboration with MTN Foundation. So in January this year, we signed an MOA with MTN Foundation where we would jointly revitalize 52 PHCs all across Nigeria. We've started that and it's been quite a progress. Please, next slide. So these are some of the facilities in Edo and Rivers states before revitalization. This is what some of these facilities look like. Next slide, you see what they currently look like. So this is what they all currently look like now, post-revitalization. Please, next slide. So this is just a tracker showing some of the states where we are and then what we are currently doing in the states. Some states we've commenced revitalization, some PHCs we are yet to commence. This next slide. So yes, I was talking about data and improving service delivery, and that should show you the data from these facilities in terms of service delivery. So the first red and yellow bar here shows service delivery in terms of ANC attendance. I think we've surpassed that by over 300%, an over 300% increase in ANC attendance. And the second one, sorry. Yes, the second one is antenatal. Okay, the first is OPD attendance. We are currently at, okay, so this is comparing the baseline data with what we had as at the end of 2023. In 2022, OPD attendance was 2,492 for these facilities, but at the end of 2023, we almost doubled the figure, and then we currently have a figure of 4,769. For ANC care, yes, because the facility was not in good shape, they did not even have service providers and people to take skilled workers to take deliveries. We had ANC as 258. As at the end of 2023, it came to 895, about 300% increase. For number of birth attended to by skilled birth attendants, we had 147 before we took over these facilities, and it almost doubled to 288. And same for children immunization. It was 2,061, and then it became 2,231. Next slide, please. So I know many people might at this point be thinking, how do we join? How do you become a part of the ADHFP? So we have different mode of entering into the ADHFP, different ways on how people can become a part of the ADHFP. And one of it is the full adoption. a group of an individual, an organization, or more than one individual come together and might decide to adopt any PHE at all. And then this is done for a period of 5 years, and this cost covers infrastructure, drugs, medical equipment, staffing, and running the PHCs for the 5 years. We also have partial adoption, where the person decides to take maybe out of the 5 years, I just want to run this PHC for 2 years. I'll take the CAPEX and then maybe 1 year of the OPEX. So we also have that arrangement, and that is the partial adoption, the one on the right. Next slide, please, Clifford. We also have co-adoption. So we have 2 people come together, or just one person interested in infrastructure and drug, another person is interested in medical equipment and staffing. 2 or more people can come together, or even organizations, 2 or more organizations can come together to co-adopt a PHC. Yeah, so, and that is the breakdown on the left. We also have in-kind donation, where people can decide to donate in kind. So it could be infrastructure, it could donate drugs, it could be medical equipment. Of course, this has to go through the SPHCDA for us to verify that it is the standard they would like to work with. We also have civil works donation. There are people that just want to, okay, for the renovation, everything that has to do with the renovation, the building, borehole, we'll cover that, solar panel, we'll do all of that. So there are people that can actually do that. We also have the civil works donation if you cannot do the full adoption. Next slide, please. So what are some of the benefits for adopters? We have enhanced visibility and recognition. Adopting these PHCs also provides some form of visibility to the adopters. We have sharing knowledge and expertise. We have different forum with the government and then with other stakeholders where potential adopters could share their expertise and their knowledge in terms of what they do and what they do. Then it could also be a form of CSR, of social responsibility to the host community. And then I think this is one that people have leverage on for most of our adopters, is a form of social responsibility to their host community. So I don't know if you noticed from the other slide I shared on our adopters, most of the PHCs adopted were in their states, in the states where the adopters come from. And then so many other benefits for the adopters. Please, next slide. Next slide. So another benefit please, the slide further. So another benefit that I did not mention is the opportunity for networking and partnership. We have partnership with all of these organizations listed here: the WHO, MTN, Sanofi, Access Bank, Gavi, Jimovia Foundation, Zenith Bank, and all of them. So a partnership between PSHAN and potential adopters would open door for potential collaboration that could greatly enhance and transform the healthcare services in Nigeria. So for us at PSHAN and the ADHFP, our goal is to provide equitable and affordable healthcare to everyone, especially in the rural communities and at the grassroots. We want to be able to provide affordable healthcare from Port Harcourt to Port Toscom all over Nigeria, to make sure that even every child celebrates even more than their 5th birthday, and every pregnant woman is able to deliver safely, and we are able to achieve all our set targets by the WHO and other international bodies. Thank you for listening to me.
Thank you so much, Rukayat. That was very insightful. I think one of my take home would be that healthcare in Nigeria is something that everyone should be actively involved in. And I think the ADHFP initiative gives us that opportunity to not only lend our voice, but also contribute to advancing healthcare affordability, accessibility, and quality in Nigeria. Thank you so much once again. That was very insightful. Next would be a keynote presentation by Dr. Leke Oshuniyi, who is the chairman of the Health and Managed Care Association, Nigeria.
Thank you very much, Mr. Clifford Bomiade. Good morning, everyone. permit me to stand on existing protocols and permit me to thank the prior speakers, Dr. Akinbolagbe, Drs. Anyachukwu and Dr. Sadiq, for their presentations. Now, we've heard a lot about how bad the health situation in Nigeria is. But what is even more frightening is the fact that our health indices are deteriorating. There's a health index, which is not often used, but which signifies a statistic that signifies premature death. So with 220 million people in Nigeria and a life expectancy of about 55, when you compare that life expectancy with the life expectancy of our neighbor, Ghana, which has a life expectancy of 65, there's a 10-year gap. So what that 10-year gap translates to is actually the population multiplied by the gap. So there's a years of life lost, 2.2 billion years of life lost is what it translates to if you look at it from the Nigerian perspective. And if you take a life expectancy of 75, you're talking of 4.4 billion years of life lost. It's a frightening statistic. And I think that this conference will help us to highlight the catastrophic situation in our health sector. Before we embark on the road to universal health coverage, we need to know where we're coming from. And perhaps this will spur us to greater heights and galvanize the entire country, both public and private sectors. So the title is Harnessing Private Sector Solutions for UHC in Nigeria's Evolving Health Insurance Landscape. Can I have the next slide? So that's the WHO definition of UHC, universal health coverage. Everyone has access to the full range of quality health services when and where they need them without financial hardship, and covers a continuum of essential health services, promotion, prevention, treatment, rehabilitation, and palliative care across the entire lifespan. So that definition captures everything that we need to know. I often liken healthcare provision to flying to a destination by air. Not everybody can sit in the first class section or in the business class section, but everybody who gets onto that plane lands safely at the other side. So the mission is accomplished. It's just a question of how comfortable the trip is. I believe that sums up the concept of health equity, that everyone who embarks on that journey gets well. Philanthropist you must have heard of, an anthropologist, Margaret Mead, who was asked what she thought of the trend of human civilization. And she said that the most significant thing she found was a healing fracture in one of her excavation sites. It meant that people had taken the time to care for that person who would have expired from all kinds of hardship if that fracture had not been healed. And this brings me to the concept of carrying everyone along and no one being left behind in our healthcare space. It's just an indication of how much as a society we care. Next slide. Almost exactly 76 years ago, there was a great event that happened, which at the time may not have been received the kind of recognition which it should. A country just coming out of the worst conflagration in human history, the Second World War, threw out a conservative government and installed a Labour government, which decided to commence UHC. And it was 100% adoption from the first day. It was on the 5th of July, 1948. The Minister of Health was a man called Henry Bevin. The country was United Kingdom. Irene Bevan had worked on the theories of a man called William Beveridge, and the NHS that we know today in the United Kingdom, one of the best performing health systems in the world, started on that 5th of July, 1948. Of course, the payment for this service was by tax. One of the reasons why we're embarking on this health insurance journey is because Nigerians don't pay as much tax as they should. We pay a quarter of the percentage of the tax of South Africa. If we pay proportionately what South Africa is paying, we won't need health insurance. Government will just pay for health. It costs about maybe 6 or 7 trillion, but government will be able to afford to fund the health of everyone. Next slide, please. So Nigeria is not alone, but because Nigeria is a quarter of sub-Saharan Africa, it's a good place to start from. Sub-Saharan Africa, it is said, carries a quarter of the world's disease burden, and yet has only 1% of global health expenditure. And this is why almost half of the world's deaths of children under 5 take place in this area. So if 50% take place in sub-Saharan Africa, you know that Nigeria has at least 12% of that death toll. Next, please. Next slide, please. So a very kind German platform ranked us as having the 157th best health system in the world. This is just a polite way of saying Nigeria has the 10th worst health system of 167 countries. And others grouped with us in worsening order: Angola, Guinea, Liberia, Eswatini, Sierra Leone, Somalia, Lesotho, Chad, and the Central African Republic. We're in very, very bad company. Very bad company. Next, please. Let's remind ourselves of the numbers, which may actually be underestimated. Maternal mortality ratio is around 14 deaths per 100,000. Mortality rate for infants is 70 per 1,000 live births. Mortality rate for children under 5 years is 104 per 1,000 live births. Life expectancy is about 55. Malaria, we have about 68 million cases and almost 200,000 deaths in 2021 alone. And we account for more than a quarter of the global malaria burden. Next, please. TB prevalence is 323 per 100,000. HIV/AIDS is estimated at 3.2%. Malnutrition is almost half. So almost 50% of the children born in Nigeria are malnourished at one point or the other. We're seeing rises in non-communicable diseases, hypertension, diabetes, cancers, and neurological disorders. But it's not all bad news. Guinea worm transmission was interrupted in 2013, and last wild polio virus was reported in September 2016. Now, those two last items are very significant because we didn't do it alone. We did it with the help of international agencies. So there seems to be a problem when we embark on programs without assistance. A lot of resource, should I say, is lost along the way. Now, remind us again of the ways or methods of health financing. So we have general tax revenues, as I spoke of earlier, with the United Kingdom, which pays for all the National Health Service expenditure approaching the equivalent of $200 billion per annum, is all from tax. So it's possible to fund the health system using tax. Then you have the social insurance, which we are starting on now with our mandatory health law. There's voluntary insurance, private insurance, charity from philanthropists and CSRs of companies. And then we have the individual out-of-pocket expenses, which currently predominates in our health sector. People put their hands in their pockets and they spend money. We will see more of those statistics later on in this address. So what is insurance really? My definition, the simple one, is setting aside enough money for a rainy day. And what is enough money? Well, that's where the rub lies. Enough money requires some very, very intricate calculations to determine what is the entire need of a country for healthcare and how much is it going to cost. So we put in the health risk into one pot and put the required funding into a pot so that whenever the health risk crystallizes, we draw from the pot. So we're pulling risk and we're pulling the funds required. That simply is insurance. Sometime in 2001, heads of states of African countries came together and agreed to pledge at least 15% of their annual budget to improve the health sector. They didn't forget to add a plea for donor countries to spend less than 1% of their gross national products. But significantly, regarding the 15%, Nigeria has hardly ever crossed the 5% mark. We've always hovered around the 5% mark, which is a third of the target. If we were doing 15, then a lot of the problems we have will not have materialized. At 5%, we are spending about the equivalent of $1 billion a year. Of that $1 billion a year, $800 million is recurrent expenditure. So our capital vote on the national budget is just $200 million or $1 per person per annum. That's not going to develop any capacity in the health sector. Next slide, please. As I said earlier, 5% about $1 billion. Next slide, please. Incidentally, the state governments also spend an aggregate of about $800 million. So the total government health spend in Nigeria is slightly under the equivalent of $2 billion US. Now, compare this with the UK, as I said earlier, they spend £3,000 per capita. The USA spends $12,000 per capita. Of course, that translates to $4.4 trillion for the healthcare in the USA. Switzerland is $8,000 per capita. Netherlands, 6,799 per capita, and Cuba is 1,200. The highest estimates for Nigeria are about $70 per capita. But if slightly increased or maybe tripled, I think we can get a lot of traction if we spend as low as $200 per capita aggregate health spend in Nigeria. Next, please. Now, before we come to the new law, the National Health Insurance Authority Act of May 22, 2022, it's important that we look at the previous law, the NHIA Act of May 29, 1999. Clearly, it failed. It failed because it wasn't compulsory. And so we lost 22 years and 350 days, or 345 days, because it wasn't compulsory. We would have embarked on this journey much earlier if health insurance had been made compulsory in 1999. Depending on who's delivering the statistics, a coverage of about 3 to 10% is often ascribed to our health insurance coverage. I doubt those figures. From what I know, about 2 million citizens are covered under the formal sector plan for civil servants. About 1 million or 2 covered by private health insurance plans. The state plans are not yet very well established, but Lagos State is doing extremely well. And I think has a few million now enrolled of the 22 million people in the state. Lagos State is at the forefront. Delta State is also doing very well. But the actual statistics have not yet been published. We need more studies to let us know the coverage. Next slide, please. The old law was over-centralized, and very little was said about states. In fact, when we set up a committee in the year 1999 in Lagos State, we found that the state was not sufficiently enabled. So a whole law had to be written for Lagos State. This was done in 2014, before we could even move ahead with the state health insurance in Lagos. And the same was happening in all the other states. No state had a health law before 2014, 2015. Next slide, please. Now, the PPP model was adopted by the founders of health insurance in Nigeria because they wanted to synergize the energies of the private sector with the sheer might of the public sector. But this synergy didn't really catch fire. It's important for the public sector, which is much smaller than the private sector. I said a few days ago that our national budget has hovered around the $25 billion mark since Shagari's time. Always, you can convert it to Naira, but what you get is about $25 billion. If you compare that with the private sector, which generates the GDP of a country, we have a GDP of $500 billion. So the private sector is actually more than 20 times larger than the public sector. But the public sector never lets us realize that. And it seems that the public sector has a problem with private sector operators driving for sustainability. Because if a corporate entity is not sustainable, then it cannot continue to do what it's been doing or what it plans to do. So there needs to be better understanding so that there can be mutual collaboration and growth. Next slide. So as I said earlier, the public sector doesn't understand the dynamics and necessity for profitability in business. They just think, these people have come again. They want to come and make money. No, there is value for money, is what the private sector often offers. And this is accepted globally. One of the examples is the fact that even though it was a PPP, there was no actuarial computation done for 12 years. So the figures for 2012 for premiums in the formal sector program remain the same, despite the fact that there was a 10-fold increase in or decrease in the value of the currency. So at an exchange rate of 140 to 1 in 2012, capitation was 750 Naira per person per month. At an exchange rate of 1,500 Naira to the dollar, the capitation is still 750 Naira per person per month. So those of us participating in this scheme are actually subsidizing government. The private sector company subsidizing the public sector is unheard of and is not sustainable. We hope and we know from the next slide that with a new DG in place in the NHIA, there will be change. That change is already happening. Next slide, please. So, is this NHIA Act of 2022 perfect? No. Regrettably, there's no perfect law. The statute it makes social health insurance mandatory. That means every one of us, under the sound of my voice, are expected to pay for social health insurance. And the going rate is probably about 15,000 Naira per person per month, although that is a very low value. That's the going rate, because we haven't got the new actuarials in place. What we thought and what we advocated for was that health insurance, not social health insurance, should be mandatory. What does that mean? Now, if we had a mandatory law that said, look, you can bring your health insurance, It can be from government, you can purchase it from government, or you can purchase it from the private sector. It would be like vehicle insurance, where you can either have a third-party insurance or you can have a comprehensive insurance. But if the law was that everybody should have third-party insurance before getting comprehensive, most people would just stop at the third-party insurance level and not even bother, since both of them, are admissible. And that's the problem we may face, that the uptake of private health insurance might be jeopardized by the fact that the social health insurance is what is mandatory. But we will see how that pans out in the months and the years ahead. Next slide, please. We have a brand new DG, we have a brand new act, and we have an opportunity to make a fresh start. I am aware, that actuarial computations are being made right now, and stakeholder meetings are being held, just to make sure that we start off our journey to UHC on the right foot with the right numbers. As I said earlier, insurance is about putting away enough or setting aside enough money. Right now, we're not setting aside enough, and the outcome is that there are shortcuts in caring for the citizens of our beloved country. Next slide, please. Now, the survey of multidimensional poverty in 2022 revealed that we had about 133 million people who are multidimensionally poor. We've determined the base premium from current rates, inflation, and so on, to be about 40,000 naira per person per annum. This, we think, will cover most of the health requirements of someone who cannot afford to pay for healthcare. So the amount required for healthcare would then be the product of the price and the population, which will give us a figure of approximately 5 trillion naira. Now, 5 trillion naira is about a quarter of our funded budget of 20 trillion. There's no way we can afford that from government spend alone. Next slide, please. Now, the figures on this slide are a bit small, but it's from the National Bureau of Statistics, and it tells us how much we're spending. So, of a household expenditure in Nigeria in 2023 of 40 trillion, 6.12% of it was spent on health. And that translates to 2.4 trillion, or let's say 2.5 trillion. We'll round it up. So this is a good indication that the figures for the premium, which we calculated in the previous slide of 40,000, is quite realistic, because the people who spend this money are the 70 million who can afford to pay for health. So 70 million people pay 2.4 trillion, and 133 billion who can't afford it will pay something like 5 trillion. So there's correspondence between the figures. In short, we'll probably need something in the region of 8 trillion naira to accommodate the spend. If that money came into the health sector and it's very well disbursed, then I think that we will probably be looking at health indices close to Ghana, which has more than 60% adoption of health insurance. So that really is the kind of money we need to bring into the sector. Next slide, please. So this triggers off a number of discussions. We know that currently private health expenditure is about 70%, some people say 75% of total health expenditure. The problem with these monies is that they're fragmented. So someone goes to a pharmacy and buys something for a headache. Someone has a fracture and buys some care from an orthopedic hospital. The problem then becomes that of the taxi driver who does not know what he's going to earn in one day. So he can't plan. And at the end of every day, he looks at the money he's earned and says, oh, there's going to be more money coming in tomorrow. Let me just spend this one quickly. Long-range planning is very, very difficult when cash flows are fragmented. Now, those figures I have mentioned, the requirements for maybe 8 trillion naira to cover for health expenditure, we must remember that these are just recurrent expenditures. Estimate for capital expenditure, some people say $10 billion per annum for the next 10 years. They're huge because you have to set up health systems, computer systems, manufacture medication, build healthcare centers, and so on and so forth, train personnel. So the health spend is going to be huge for the capital part of the expenditure. Health tourism, we haven't mentioned in this talk. Official figures are 1 billion from central bank. But I know for certain that most people who go abroad are sponsored. They buy their currency on the parallel markets. So the true figure is probably about 2 to 3 billion US dollars, which is the same as the government budget. So we need to harness all these things and keep the funds in country. Spoken about the tax to GDP ratio, talking about the SACRA tax to GDP ratio. But increasingly, policymakers are thinking of widening and deepening the tax net or increasing the percentage of VAT or charging healthcare to sin taxes, sweet and sweetened beverage taxes, telco taxes, diaspora remittance taxes, and so on, just to find a solution to bring that 5 trillion into the health economy. Next slide, please. Now, as I was reminded just 2 days ago, the private sector is not just hospitals, HMOs, and enrollees. It's actually everyone, more or less. So on the supply side, of course, there are the healthcare delivery centers and so on. But you also have people who will build those centers, the people who will manufacture the pharmaceuticals, the architects, the equipment suppliers, alternative energy solutions, training centers, banks who fund all these ventures, telcos, fintech companies, those who write the software. And on the demand side, of course, in the private sector, you have the HMOs who are buying healthcare, corporates, philanthropists, individuals, etc. So we're all involved. Ultimately, everyone is a private sector player. Even if you work for government, you're going to use your salary that you earn in government to come and buy care a lot of the time, buy medication and so on and so forth. Next slide. So, ladies and gentlemen, I've just tried to capture the needs of this our journey, because those things don't come free. We certainly don't manufacture enough of consumables or hard equipment in the health sector in country. So there's going to be a lot of expense. We must be prepared, and our eyes should be on raising the necessary finance, apart from the other things. But there is a need for hard cash. And my message to you today is that no rock should be left uncovered in this journey to universal health coverage. Thank you very much for listening.
Thank you very much, sir. Thank you very much. That was indeed very insightful and very engaging. I would say, just to also highlight one of the points you mentioned, that although the uptake of private health insurance might be jeopardized, since only social health insurance mandatory, but you also stated something that there's a unique opportunity for a fresh start. I think for me, in as much as there are challenges that we face in the sub-Saharan Africa region, there's still hope, like you rightly mentioned. And these are part of the conversations that can drive, tangible solutions that can be implemented to achieve universal health coverage. Thank you so much. That was very insightful, sir. Thank you. So we'll be moving shortly to the panel session. But before I do that, I'd just like to say that if you can drop your questions using the Q&A feature on just below your screen or your device, you see a Q&A feature there. So you can drop your questions and we'll be sure to take as much as we can. So next, we'll introduce the esteemed panelists for our panel session. And the panel session is titled, The Role of Private Sector in Achieving Universal Health Coverage. And to lead this discussion is Dr. Anne Adaogo, who is the Director of Policy, Private Sector Health Alliance of Nigeria. Dr. Anne, over to you. Thank you.
Thank you very much, Clifford. And welcome to everyone who is attending the conference with us today. I will be standing on existing protocol and saying, if you have colleagues, if you have friends, if you have contemporaries who are yet to join the conference, this is a good time to ask them to join us, because we will be attempting to, in a few minutes, talk about the demand side of health insurance. We spent the first day of this conference talking about the supply side of health insurance, and to every action, there's an equal and opposite reaction, as the third law of Newton would let us know. And so to attain an equilibrium when we talk about health insurance and attaining universal health coverage, in addressing the supply side, it is also important that we look at the demand side, because regardless of the amount of services that we provide, if people are not able to utilize those services, then we will be far from achieving the journey to universal health coverage. And so today we will be focusing more on the demand side of achieving universal health coverage through health insurance in Nigeria, particularly emphasizing on strategies that ensure inclusion for the most vulnerable population. Our discussion today will center on how the organized private sector can actively contribute to expanding health insurance coverage to underserved communities and the marginalized group, as outlined in the Nigerian Health Insurance Act. As we heard from the keynote speaker, health insurance is no longer an option. Health insurance is now mandatory. And what that means is that every Nigerian, regardless of social class, strata, or status, would need to participate in health insurance if we are to attain universal health coverage. To take this conversation further, you will join me to welcome subject matter experts who are versed in the area of universal health coverage, private sector solution providing, and all the key elements and key components that will be contributory to achieving universal health coverage through health insurance in Nigeria. To join me on this panel today is Dr. Rotimi Olatunji Oluwaseyi, who is the head of the Business Development Unit for LASHMA. He is standing in for Dr. Emanuela Zamba, who is the Permanent Secretary and the Chief Executive Officer of the Lagos State Health Management Agency. Dr. Emanuela Zamba is unavoidably absent. She had an emergency to attend to, and so she has sent in a competent representative. Please make warmly welcome Dr. Rotimi Olatunji Oluwaseyi. Also joining him on this expert panel today is Mrs. Vivian Ihekwazu. Mrs. Vivian Ihekwazu is the Managing Director of Nigerian Health Watch. She's a health communication and Nigerian Health Watch is a health communication and advocacy organization based in Nigeria, advocating for improved health and access to health care services. Mrs. Ihekwazu, you're welcome to the expert panel. Also joining us on the panel discussion today is Ikechukwu Ofuani, who is the Director, Worldwide Government Affairs and Policy, West and Central Africa for Johnson & Johnson. Ikechukwu Ofuani is a government affairs and public policy practitioner whose experience cuts across Europe, Middle East, and Africa. He currently leads the government affairs at Johnson & Johnson. Mr. Ofwani, you're welcome to the panel discussion this morning. Joining us on the panel as well is Dr. Oluwakayode Abayomi, who is a group medical consultant for Dangote Industries Limited. Dr. Abayomi has a master's degree in public health and provides technical capacity building in fields like primary health care, emergency, pre-hospital care, public health intervention programs, health management systems, occupational health, health policy formulation, and advocacy. Dr. Oluwakayode, welcome to the panel discussion this morning. Joining us as well on the panel is Kenneth Okoli, who is the Managing Director and CEO of SynLab. He oversees the day-to-day operations and overall management of the organization. Kenneth is an experienced business leader in the healthcare sector with a demonstrated background in medical diagnostic services. Kenneth Okoli, you're welcome to the expert panel conversation this morning. And last but not the least is Dr. Maurice Atoke. Dr. Maurice is the Chief Executive Officer for the African Business Coalition for Health. Dr. Maurice, ABC Health is a social equity organization focused on mobilizing private sector resources to improve health outcomes in Nigeria. Maurice's career spans across various fields in both the public and the private sector, where she has established herself as a skilled business strategist and an expert in organization strategy. Dr. Maurice Atoke, welcome, and it's a pleasure to have you as always. So just to quickly set the tone for this morning's conversation, where we are going to be looking at the role of private sector in achieving universal health coverage. The National Health Act, which was modified in 2022, was first established in 1999 and established the National Health Insurance Scheme to provide universal health coverage and improve access to quality health care. Despite its inception over 2 decades ago, enrollment has been sluggish, with only about 5% of the population covered by 2018. This limited uptake is significant, considering Nigerians' per capita income of $2,097 and a life expectancy of about 54 years, which underscores the need for broader healthcare access. Out-of-pocket expenditure in Nigeria for health accounts for over 70% of total healthcare spending and places a heavy financial burden on households. As healthcare spending constitutes approximately 3% of Nigeria's GDP, enhancing the demand side of health insurance through increased awareness and improved enrollment is critical. Strengthening the National Health Insurance Scheme participation can also mitigate financial hardships, improve health outcomes, and contribute to economic stability by reducing the economic strain on families and aligning with Nigerians' broader economic goals. So it is with these few remarks that I would like to set the tone for this morning's conversation, and by asking all panelists to please come in with 1-minute pitch that speaks to improving universal health coverage through improved health insurance for the most vulnerable population in the community. So in no particular order, I would like to start with Dr. Maurice Atoke. Just your 1-minute pitch to kickstart this conversation. Thanks, and over to you, Dr. Maurice.
Thank you very much, Dr. Ann, and thank you to the PSHAN community for this opportunity to be part of this the panel for this very important topic. I must also appreciate the keynote speaker, Dr. Leke, for that very insightful and deep speech, ahead of this panel. Now, if I've been given 1 minute, so I'm just going to try to be short about it. My 1-minute pitch will be a lot of knowledge exchange across borders, and learning from what other countries that have succeeded, especially within the continent, have done will be a very good way to assess, potential success in health insurance coverage across Nigeria. And so for me, I will piggyback on my learnings in Egypt, the Egypt Healthcare Authority, who have adopted an approach called similar to pay as you earn. So again, insurance is mandatory for everyone. I mean, look at that. But everyone they don't get to pay the same amount. So you pay whether you are a organizer, whether you run a salon, whether you work in a salon, whether you just plot here, you pay by what you earn. However, everyone has access to what the government have provided as infrastructure in terms of, healthcare. And so for me, this just really raises a lot of thoughts. And the thoughts are that, can we arrive at such a, equity and equality position as a nation in Nigeria, where we get the 95% who live below extreme poverty to have the same access to the same health infrastructure that people like you and I, Dr. Ann, will want to be treated, hospitals where we will want to be treated. And so for me, that's a question I would like to put out there to both private sector and public sector. We should be thinking in that direction.
So,
and
Dr. Morris,
thank you very much.
So we're looking at equity and equitability through learning from countries who have gone ahead of us in your 1-minute pitch. Thank you very much. I'll move over to Kenneth to give us a 1-minute pitch as well.
Thank you very much, Dr. Ann. I think Dr. Leke really did a good job shedding light on a lot of gaps which we have existing. And I think, taking a note from the day one, we all agreed that we need to find some local solutions and perhaps innovate within our central space. And one of such innovations, I'll take a leave with what is happening in Ghana, and I think Kenya also, where they realize that a lot of people are earning very little. They may not have the money to pay, like Dr. Leke pointed out, 40,000 naira in bulk for healthcare at one go, but all of them use their phones. They buy data, they buy credit, call credit. Is there a way we could leverage on that for them to finance their health insurance needs? Okay, using such opportunities helps to deepen access. Because if we're all waiting for when everything is all good and fine, I think we may be missing the boat. Like Dr. Leke pointed out, we've already lost, I think, 20-something years, all right, just because the act was not right. I think that we can really leverage on existing infrastructure as they are and gradually build on it. Okay, so my parting message, or my 1-minute speech would be, how can we leverage on existing tools, existing financing mechanism, existing habits, okay, to pivot into what we really want in terms of financing for the most vulnerable in the society.
Thank you very much, Kenneth. I will come back to you with those conversations around using existing income or budgeted expenditure to expand financial health coverage for the most vulnerable people. So I'll come right over to you, Vivian, in terms of what your 1-minute pitch is, given all of the work you have done around advocacy and ensuring that people are adequately informed and can demand the kind of health insurance that provides affordable yet quality health care for the most vulnerable Nigerians.
Okay, thank you very much, Dr. Ann, and thank you very much to PSHAN for inviting me for this conference. I think you really said it there, and also some of the other speakers already mentioned it, including Dr. Leke. I think what we really need to think about in Nigeria is how do we, of course, increase access? But increasing access means people have to be aware and understand what health insurance is in the first place. So very quickly, what I would say in summary is, one thing that is very missing in Nigeria is people understanding what exactly health insurance is. In as much as there is a law that has made it mandatory, there is existing data that shows that many people do not even understand what health insurance is. And even if they do, access is very poor. One thing that Kenneth mentioned is existing platforms. We have social welfare programs that are already existing in Nigeria. We just need to find avenues to use those existing platforms, especially the social welfare ones, to expand access to the most vulnerable who, get, stipends monthly, but using some of that existing funding to provide them health care. Over.
Thank you very much, Vivian. Knowledge is power. And so how do we know, how do we help people not just to know, but when they also know, use the knowledge they have to acquire the health that they desire? That's also a good place to leave it. And I'll come over to Dr. Olua Kayode and ask you to give your 1-minute pitch.
Thank you very much. Good morning, everybody. I want to thank PSHAN for this program. It's a very wonderful platform to discuss about health insurance in Nigeria once more. My take is very simple. We have tried so many programs. We've tried the NHIS, which Dr. Deke said failed. We've tried community-based insurance. We even tried voluntary contributions. But I think that we are a peculiar nation, and we should look for our own solutions. Why it's good to to look at what other countries have done, like other speakers said, in Ghana, in Egypt. But I feel that we can develop our own homegrown solutions to the issue of UHC. And I will talk about use of technology. That's where I stand. This is technology age. We can't depend on just brick and mortar, alone to solve our issues. We need to find, those health connector programs that can build, that capacity that we so much crave for. I will pick back on what PSHAN is doing, which I think is one of the major ways we can achieve UHC, where the rich, can, fund those PHCs and allow, the poor, the less privileged, to benefit from that, and it's not only benefiting, it's also creating that awareness whereby they know that these centers are for us and we need to make use of them, because I found out that there's also a disconnect between making centers available and people also using those centers. And that's communication, with people and the community. So my take is, of course, also telemedicine has come in now to also bridge that gap. We don't have to also go to your hospital physically, to access care. So we can reach out more through technology, analyzing disease trends and, making sure that the right people get the right treatment, en masse. So for me, I'll crave for technology, to come into that space, and obviously crave for what PSHAN is doing, let more people adopt those centers so we have more structures to service the people. Thank you.
So thank you, Dr. Abayomi. We are looking at peculiar homegrown solutions to Nigeria's own problem. We can learn from other countries, and then we develop our own homegrown solutions to fix our own problems. We're also looking at the option of the rich subsidizing the poor so that we have equitable quality access to healthcare. And we're also looking at the use of digital technology. All of these are concepts that we will build on in the next half an hour in terms of having a conversation that increases demand for health insurance amongst the most poor and the most vulnerable Nigerians. So I'll come over to you, Rotimi, in terms of the work that you have done developing business for LASHMA, to give a 1-minute pitch as to how you think we can achieve universal health coverage through Nigerians subscribing for more health insurance. Over to you, Dr. Rotimi.
Top of the morning to you, everybody. Dr. Han, I'd like to appreciate you for quickly awarding a degree in medicine to me in just a few minutes. I didn't know it was that easy. I would accept it. I'm Mr. Rotimi Atunji, not Dr.
Okay.
Many thanks to Dr. Akimbolagbe for putting this together and your team. And of course, the insightful delivery by Dr. Ebere Farouk, Dr. Farouk, and Dr. Oshuni. Now, I did like to be very straightforward. I think innovation and creativity is what I will stick with to deepen and promote universal health coverage in a space for Lagos State. A practical experience that we have had in the informal sector and the vulnerable space is quite similar to most experiences other people must have had. I think people, of course, don't understand the subject matter of insurance, one. And two, they don't want to understand that subject matter of insurance for so many reasons. But I think that we've been able to do quite a lot through creativity and innovation. For us, we have a private initiative that was set in place to complement government effort in terms of resource mobilization to pay for those who cannot pay for themselves. And we've done quite an extensive work within that space, having people who are the poorest of the poor, classifying them into various categories, and making premium provisions for them so that they can access care without any form of hindrance. And so lately, we have also partnered with Sterling Bank. The financial institution is one of the big industry space where we can tap into collaboration and partnership. And over the years, I've seen that space as a space where it's actually the uptake is quite slow a lot of times when they need to collaborate with big initiatives, especially in the area of health. But Sterling Bank has done well, and we have built some level of virtual clinic in identify hospitals as pilot projects in Lagos, because we realize that even if you have a trader with a net worth of business of about just 5,000, maybe selling a few stuff, they will never leave that place to go to an hospital. It appears they prefer to die there rather than leaving that store to go to an hospital. So the virtual clinic is...
Mr. Rotimi, you're already on the roll. I see the passion and I see the amount of work that has gone in, seeing how easily you speak to some of the, in fact, you've preempted most of the questions that we are going to have as conversations regarding LASHMA. So I will come back to you and we will continue the discourse immediately. I have reminded all our participants and attendees online to please put your questions in the Q&A chat box so that we can respond to them. You have an opportunity to ask the subject matter experts during the conversation. So please put your questions using the Q&A platform, and we will be sure to collate those questions and get them answered before we go from here as best as we can. So I'm going to ride on the conversation with Mr. Rotimi. I would like you to highlight, you already started some of the creative ways that you're resourcing health insurance in Lagos State. I would like you to speak to some of the challenges which you already mentioned, one or two, and then what the direct strategies are to address some of the challenges and how successful it has been. So can we go through that?
Okay, thank you very much. Like I said earlier, if you look at, we're a bit biased about the target audience we are currently dealing with, which is largely the informal sector and those who are not able to pay for themselves for economic reasons. May it interest you that the Lagos State government makes provision for the equity fund to pay for the less privileged and the vulnerable within us. And we work closely with some relevant ministry and agency of government in identifying who these vulnerable people are through some partnership with international organizations. Like you said, we develop tools in doing this identification. So we have the structures on ground, and then we are able to make sure that money is available rather for these vulnerable people. And through the first line charge that Mr. Governor has approved for Lagos State, we are able to get 1% of the consolidated revenue fund of Lagos State for the vulnerable. As I speak, over 1.6 billion naira has been spent so far as premium in covering the vulnerable. And what we do further is also to be able to complement what government does with our private initiative that we call ECOSHA. That's the Eco-Social Health Alliance. It's a resource mobilization arm of the agency. We collaborate and partner with the private sector to be able to mobilize private funds to complement what government is doing. Because if you look at the vulnerable list in Lagos through the Bureau of Statistics and the Ministry of Economic Planning, the list is long and inexhaustible. So a lot of funds are required to be able to solve the challenges that we have on ground. So coming on to the physical interface between the vulnerable, the large population informal sector, in terms of access to provider, we have moved access closer to these people that we are targeting by partnering with Sterling Bank and speaking to other banks and other big players in the financial institution to be able to provide some level of support. And so what we have done is to backwardly integrate. So our backward integration strategy has given us opportunity to provide virtual booths in strategic locations. The intention is to provide about 300 of these booths in large markets and informal sector spaces in Lagos. We have in Sabo, in Ikorodu as I speak. We have in Ketu. We have in Ekpe. So we have in 5 locations, and we're about to, Mr. Governor is about to launch.
So just while we're talking about all of this, which to me seem very focused on the demand, on the supply side for health insurance, the conversation that I would like to see is, with all of this support that you're providing to the most poor and the most vulnerable, how has that improved the demand? How has that encouraged more people to seek healthcare because there's a health insurance that's now affordable? How have you seen that significantly impact on your healthcare indices, your maternal mortality rates, your infant mortality rates, the child mortality rates, and all of the other rates that you have? How has this led to people demanding more? Are there people who have moved now from being unable to pay to becoming willing and able to pay now because they have seen the benefits of health insurance?
Oh, thank you very much. Indeed, part of the embellishments that we have in all of this supply intervention chain is that the nexus between that with demand side is that we've also been able to make our premiums very flexible. And so we have this pay small templates that we have, which is also digitalized, and you could also pay manually. We have a USSD platform. So the digi aspect of payment interface is quite popular with the informal sector and the retail end of the business in Lagos. So people are able to pay as low as 1,000 naira a month, and they're able to access the same quality care compared to those who are able to put their premium on. So we have more people adopting the Lera Eco brand, the social health insurance of Lagos State. The portfolio that we currently have shows that we have an average of about 50 to 100 uptake within a month in certain divisions. So our portfolio is showing about 25 to 40% increase in uptake across board within all local governments and the 5 Ibile divisions in Lagos. So the increase is huge. We also have interfaces with various sectors of the economy. The religious body also, they are increasing their uptake in that aspect. We also have people coming in, more ever than before, because you must understand that the subject matter of insurance is more sold. It's a product that you must sell. It is not bought. You must pitch to people to be able to understand why they need to have insurance. So for the experience I have had over 25 years, I hardly see people knock on my door to say, look, I was passing by and I said I should just pay for my insurance. So people are renewing, they are coming more, our retention is high, and then uptake is almost geometric as I speak. So we have close
Thank you so much, Mr. Rotimi. Thank you for sharing that improvement with us and to share the impact stories with us in terms of how health insurance is increasing, or the demand for health insurance is increasing because of all of the efforts by the Lagos State government to get people to jump on the boat. So I will go straight to Mrs. Ihekwezu Vivian to ask in terms of creating awareness, because people need to know, people need to understand, people need to be convinced, and people need to put out the foot to actually utilize the health insurance that we talk about. People need to understand what the National Health Act even is in the first place, what it mandates them to do, what it entitles them to do, and understand how to hold healthcare providers to account to ensure quality of care services in the health facilities. So how do we get them to talk the language of health insurance? How do we get them to understand and to speak health insurance and utilize health insurance? Thanks, and over.
Thank you very much for that, Dr. Ann. I think Mr. Rotimi has started from a good base, which is what is being done in Lagos State. As I mentioned in the opening, there's one thing, people being aware, and then the next thing is access. If you ask the average Nigerian, they wanted to get health insurance, where would they even get it from? What you will often find is they don't have a starting point, because we do not often have, focused campaigns from even health insurance companies going to your average Nigerian, ensuring that they understand in the very first instance what health insurance is, and then second of all, how to access it. So really, as you asked in the question about what Nigeria Health Watch, does and has been doing, as you know, we're a health communications and advocacy organization. And so we have played, have tried to play as much as possible, as well as other CSOs, a role in advocating for in the first instance, policy reforms that ensure that people have access to affordable health insurance. I think there's a big focus, especially on vulnerable populations, given often they are the ones who have the least ability to pay for healthcare. And when they do have health needs, that financial burden can completely have a devastating impact on their families. So, the way we do these, first of all, even starting point with raising awareness, as you asked, about what health insurance is. We've organized policy dialogues, bringing together different stakeholders, government officials, private sector, etc. So now an example is in May 2023, we hosted a health financing policy dialogue, and this was just after the National Health Insurance Act had been passed, looking really at the implementation of it following the initial National Health Insurance Scheme. It was themed at that time, accelerating the implementation of the National Health Insurance Act. And in attendance then was our previous DG of NHIA, as well as the Director General of the Budget Office, Mr. Ben Akabueze. We have to always remember the multi-sectorial approach that we need to take when we talk about health insurance. We often kind of constrict these conversations to the health sector. We have to also remember other sectors that we have to engage. So really at that stage, we were really tackling what are some of the challenges and opportunities and strategies that we need to use in Nigeria to improve health insurance coverage, particularly for vulnerable group that we keep on talking about. Is if you cast your mind back, the recommendation to even include this vulnerable group and to set up a vulnerable fund came from the Lancet Nigeria Commission that was published in 2022. And this really formed the basis of the Vulnerable Group Fund. And some of the discussions really focused on how can we look at innovative financing mechanisms to increase access to health insurance. I think some of them have been mentioned today, such as the SSB tax. How can we ensure that there are other more sustainable ways, put it that way, of ensuring that vulnerable groups actually have insurance. I mean, I mentioned one of them. We have existing social welfare schemes that we need to leverage. So one thing that's really clear, in as much as we do we put in place the legislative framework for health insurance, awareness and public education is very important, as well as looking at resource allocation mechanisms. I think most of us can think about the sort of the networks that we are in. I think for me, I know that almost every week or every other week, there's a WhatsApp group asking for funding for somebody's catastrophic health event. And everybody's starting to start scrambling and putting money together. But there must be more sustainable ways of doing this. And it's only a few people who have access to such. So there are existing examples of how, for example, the private sector has kind of leveraged this platform to kind of crowdsource funding. An example was given this morning, PSHAN's Adopt the Healthcare Facility, where the private sector has played an active role. We think also of the HIV Trust Fund and the Cancer Health Fund.
Yeah. So while I would still stay with all of the pocket of funding that we have and everything that has been made available, it remains something that has been made available until people are able to actually utilize those things. So all of the policy dialogues and all of the policy reforms that we have, a lot of times are targeted at the suppliers for health insurance and universal health coverage. How do we ensure that this trickle right down, percolates to the bottom of the kettle and have the most vulnerable people demand health insurance? What are the steps that we need to be taking? What do we need to be doing differently? Because Nigeria, we are not bereft of policies. Where we have a challenge often is the translation and the implementation of these policies to make a difference in the life of the average Nigerian. So how do we want this policy dialogue to make people demand more health insurance?
Yes, I mean, the one side absolutely is the supply side, but then the demand side also is an important one. And, a Nigeria Health Watch is a project we did in Benue State, where we worked with community-based health insurance schemes. We worked with, informal, focused mainly on the informal sector. And that work really focused on education and public awareness. And that public awareness made people understand what exactly health insurance is in real practical terms. If you're sick, most people immediately go to a health facility, if at all, or they go to the local chemist. So that work really was focused on the informal sector, going into communities, focusing on Okada Riders Association, trade market women associations. How can we ensure that they know what health insurance is, and then they have the opportunity on their own side to demand it? So that was focused community engagement to drive their demand for health insurance. So, as we talked about, one thing is to make people aware of health insurance, but in doing so, there has to be a more focused avenue for the insurers to now come to people. So there's nothing that stops a health insurance company from setting up in a market, working with trade associations, leveraging those platforms to get the volume of people who often may not have the means on their own to buy health insurance. So in getting Nigerians to demand health insurance, there has to be more focused education and direct advocacy to some of these groups to ensure that their members can get access to health insurance. And by pooling those funds, therefore, they are able to get the healthcare they need and not face catastrophic expenditure, which I think people have.
Thank you very much, Mrs. Ihekwezu, on landing it at the point where people can be informed and be more aware and encourage uptake for health insurance. So I'll go over to Kenneth, who is in charge of diagnostics. Diagnostics is a very big part of health insurance on attaining universal health coverage. You can barely do any diagnosis, and you can barely treat a patient without employing diagnostics. And we know that diagnostics are a huge cost of a lot of Nigerians, for example, would just walk into a store and buy anti-malarials without running a check because they have fever, they have things that seem like signs and symptoms of malaria. It could be anything that causes fever. But because we want to avoid the diagnostic costs for healthcare, a lot of people. So how do we ensure that through health insurance, that people can go through the right channel and demand better healthcare? So if you walked into a healthcare facility, for example, and you had an option of paying 5,000 and just picking up your medication, or you had an option of paying 10,000 because now you have additional diagnostic costs, trust me, people will opt to have treatment without diagnosis. The health insurance companies are also complicit in some of these things that happen. So how do we want to educate end users, beneficiaries, to go through the right thing, making diagnostics more available and more affordable through health insurance and getting people to demand?
Thank you very much, Dr. Ann. I think Dr. Vivian did talk a whole lot about educating the public or educating the beneficiaries of these services. But beyond educating the beneficiaries, I think just using the data that is available to me, I would say in the recent year, maybe in the last 2-3 years, we've seen an increase in the uptake of people who require diagnostic services using their insurance platforms. Well, in this perspective, I'm speaking strictly to private insurance because there's another challenge with the public insurance system when it comes to access to diagnosis. But we've seen an increase, and that is a good thing because we've seen a lot of organizations, a lot of people advocating and stating that they want to have annual checks and all of that. And it's really great. I know some organizations that have been able to reduce a number of adverse events in their organizations because of the the increase in number of people who are actually going out to do their tests, going out to have their checkups done. Now, beyond that, even though the data is not there, I'm sure there's been improvements in in the outcome of clinical care because, again, this is mostly within the private space, if I would say, because the doctors are now sure, or the medical professionals are now sure, okay, since you're not paying out of pocket, you can easily go and do a test and get the results and give me confidence on what I'm treating because you're not paying out of pocket. Okay, we've seen an increase in all of that. But having said that, there is still a lot that can be done. And when I say a lot, I mean a whole lot. And why are we still seeing a gap? We're still seeing a gap because while, yes, there is a shortage of quality infrastructures for diagnostics, but beyond that, we still have an issue with the reimbursements or the amounts charged per test. And that in itself creates some hindrance in the amount of people that will be able to access quality diagnostic services. That's a key word here, quality diagnostic services. And we've been having conversations with both representatives from the National Health Insurance Commission, different state governments, and even government parastatals that have their own insurance schemes, helping them to understand why they need to make some more money available. Otherwise, they are not incentivizing quality services. Okay, you end up with people just doing any kind of test or just using any kind of method. At the end of the day, money is spent, but it's of no help to the doctor. Remember, it's a full value chain. You go in, you complain about an illness, the doctor checks you, recommends this particular test to be done for you. So I would just conclude to say that while we've seen an uptake, which has been most significant within the private space, a lot of people who utilize some form of insurance within the public space have not been able to access a lot of the quality care that I would say maybe is available out there because of the low, I don't know if the word is capitation now, or tariffs that are being placed on tests. Okay, and I feel that this could be a hindrance to from the demand side on as to how much people will be able to access care at the end of the day. I don't know if that helps to answer the question you raised and also to drive the conversation forward.
That was super helpful, Kenneth, and indeed drives the conversation forward in terms of looking at the tariff, in terms of looking at the gaps for financing for diagnostics, particularly for quality diagnostics that will improve the quality of healthcare services. So I'm going to run over quickly to Dr. Morris to ask that in this, I see a clear opportunity for the private sector to support the demand side for health insurance, particularly for the population that we're most concerned about, the population that will, because of one ill health, suffer catastrophic financial hardships. There are times when families have to decide, do we want to treat malaria or do we want to have one meal that deals with malnutrition? So to make sure that people are not making those choices, what do you see as the role for the private health sector in terms of encouraging demand for health insurance, getting the people out there, to get health insurance to meet their healthcare needs.
All right, thank you so much, Dr. Ann. So for me, I mean, the first angle will be to critically re-examine public-private partnerships. And I say that because it's still, the biggest component and the umbrella that kind of brings together public sector and private sector interactions and engagements to foster some of these necessities and to address some of these challenges. Now, I talk about people because I did hear Dr. Leakey, even though, speak to the fact that public sector seem to think that private, don't appreciate private sector's advancements and some of the innovations and some of the result-orientedness that comes with private sector. What I want, and this is our role really in ABC Health, because we do hear from both private sector and public sector. And what we realize is that both parties, have their expertise, they have their strengths, and the ability for both parties to appreciate one another really most times helps whatever collaboration or partnerships to be fostered and to work. And for me, I believe that private sector, more often than not, and this is coming from a private sector rooted person, more often than not also needs to know where public sector is coming from. I say this because of the persistent failures of both sectors in addressing some of these huge gaps and in able to bring into the insurance nets the volume of base of the pyramid representation that is required. I believe strongly that a private sector needs to do more than they're doing. So it's not really about the funding alone. It's not really about the expertise alone. It's also recognizing what you stand to gain from the public sector. And for me, public infrastructure is the one big thing. So yeah, some of them are dilapidated, but again, the structure exists. The fact that you don't have to go to town planning to set up a structure is a big deal in the scheme of, preferring your solution. The second one is just really, and this is about galvanizing demand. The second one is just really ensuring that your competencies have to match with an existing footprint. And public sector has this footprint. They have this volume of those who are already demanding some of the services in the proposition of public-private partnership that most private sectors actually demand. And that's on the one hand for public-private partnerships. If we go a bit further, I won't talk about advocacy and policy influence because Vivian kind of overflogged that. I want to talk about corporate social responsibility initiatives, which resides majorly within the private sector net. More often than not, we don't see companies really, going out of their comfort zone to include health insurance subsidies as part of their CSR programs. And this can be largely advocated for sometimes. And I deal a lot with private sector, with companies, business communities at leadership level. They only need to be pitched to, which is from a strong advocating point of view. They can include some of these health insurance subsidies. And you will agree with me, Dr. Ann, that Nigeria, the large part of the population health requires this subsidy. It happened, we saw it with the COVID. I mean, there was no way the government alone could address that epidemic. So by funding health insurance for underserved communities, companies not only contribute to public health, but build goodwill. And that's what companies really require, is that visibility, is that reputational return to enhance their corporate, their corporate image. And so also there's technology and digital health solutions. I did hear Dr. Abayomi speak about that, so I'm going to leave that. But some of the things that private sector, and I'm not talking about private health sector now, and Dr. Ann, I'm talking about private multi-sector, which the health sector fits into. The community engagement education that Dr. Vivian spoke about, really private companies can invest in community education programs if only it is pitched to them to raise that awareness, because that awareness is valuable. It's valuable to the value chain of what we're talking about. It's valuable to the knowledge of insurance. There is no one that will understand insurance. There is no family man that will understand insurance and will not in one way want to be part of it. But mostly they don't really understand it. They think somebody wants to eat their money. I mean, we heard from the first day of of the physical conference, where one of the panelists was saying that the way we're wired sometimes is that in the course of the year, by the end of the year, if our insurance money is not spent, we take our family members there and say that, just let me check them, just so that we can spend this insurance money. And sometimes, and this is not the base of the pyramid, I know people, elites, that think like that. So there's a level of reorientation that needs to be done. And private sector can invest in that reorientation, in that, acceptance of insurance, in galvanizing and in ensuring that people actually buy it. The last one, Dr. Ann, for me, is subsidies and incentives. We operate in a nation that has been disappointed. Majority of the people have been disappointed in a lot of solutions that we have proffered. So it's no fault of anyone who is a bit skeptical about jumping into these schemes or agreeing with us in order to, maybe just enhance demand. The private sector can offer subsidies. We can offer incentives for purchasing health insurance. For example, employers in both formal and informal sector can include health insurance as part of their employee benefits, potentially covering not just employees, but also their families. So these are innovative ways that we can think about it, on the one hand. And on the last hand is risk pooling and reinsurance. Risk pooling and reinsurance, and also micro insurance. There is no way the financial institutions alone will fall below those, really ridiculous interest rates for the sake of anyone. Micro insurance organizations needs to be the ones to take responsibility more for this category of beneficiaries we're talking to. And risk pooling and reinsurance is also an insurance method. Private insurance can collaborate with one another to create risk pools and insurance schemes that spread the financial risk associated with insuring low-income populations. And I know you want to stop.
Thank you so much. Yeah. Thank you so much, Dr. Morris. I hear about reorientation. I hear about health subsidies, risk pooling, risk insurance, micro insurance, and getting the word out there and getting private companies to add health insurance to and health subsidies to their corporate social responsibilities. I will take this conversation now to Dr. Oluwakayode Abayomi to look at the role of digital technology in ensuring that we galvanize people, particularly those at the bottom of the pyramid, to taking up health insurance. I'm sorry, before you go, I'd also like to encourage online participants to please put their questions in the question and answer box so that at the end of this, we can collate all the questions and have our expert panelists speak to your concerns. Thank you, and over to you, Dr. Abayomi.
Thank you, Dr. Ann. When it comes to universal health coverage, we need to understand the components first before we even talk about technology, right? Everybody's talking about, the spread, the access, the numbers we want to cover. But I think for me, it's also important we talk about addressing those 5 components of universal health coverage. Vis-a-vis one, health promotion, right? Prevention, treatment, rehabilitation, and palliative care. So, but all attention is driven towards the curative part of the health insurance. Meanwhile, the other 4 are very, very important. Otherwise, we won't have a healthy community. But how can we do this? We can scale it up through technology. Obviously, today is technological age we are in, and then we see a lot of virtual things happening. I don't have to go to the hospital before I receive treatment. One of the key things that the global health bodies are driving is what we call self-care. So self-care is a form of care whereby you don't necessarily have to see a doctor, right? You can take care of your own health, to some extent at home or in the remote areas. And that is what we are advocating for. And self-care is a form of wellness, which I'm going to delve into a bit. When it comes to health coverage, I prefer, I would like to spend time on the preventive side of things because the healthcare funding gap in Nigeria and Africa is so huge that I don't see I want to cover that in the next 10 years. It's in billions of dollars. But guess what? How about preventing, these issues before they happen? So prevention is key when it comes to UHC. Prevent them, by virtue of awareness, Dr. Anna Miss Vivian has talked about that. Vivian has talked about, creating awareness in communities, about how to prevent chronic illnesses. It's shocking to know that Nigeria has over 60 million workers, right, who are exposed to, hypertension, diabetes, cancers, which are the core things that are really killing, the people. But I mean, how are they covered, if they don't have money to pay for insurance? We said it already, very few people are under the insurance scheme, right? But what can these people do in the meantime? How can they get some level of health care, to have some form of health security, in those environments? So for me, technology can bridge that gap. It can save a lot of life, by virtue of even just information, and communication. Recently, we launched a program, it's a QR code program where we can paste in public places that people can scan. It's a 2-minute video. You can scan and you can know what to do during an emergency. As simple as that. Just carry your mobile phone, scan it, right? And it will direct you what to do if somebody collapses beside you. That is what I'm talking about. And that's a form of health coverage too, because we don't have to wait for ambulance to come before you do something, or the other person dies right in your front. So innovation and technology has come to stay. For me, health coverage. Another one is, the corporate sector, which I belong to. What is happening there right now is that there's a gap, like I see, between the health insurance providers and people that need the health services. It's all about, I want to go for surgery, I want to maternity care. But guess what? What about having a workplace wellness program that will be a first point of call? So that everybody working in that space can access health very quickly, even before going to the hospital, right? And those programs can be tailored to individual risk and company risk. I mean, from companies that I cover, they've made a robust program that is risk-based, targeting those industries. If I buy a health plan, insurance plan, and I'm for example, I'm in a mining industry, and my health plan is just telling me about treatment, malaria, pneumonia. It's not talking about, the risk that I face at my job, inhaling, maybe asbestos and, silicon. It's not putting in place, how do I screen myself, my lung conservation programs. For me, that is not quality. It's just quantity, right? So, I mean, health insurance for me must be risk-based. Before you can come and sell me a plan, make sure your plan covers my own risk. It can't be generic. Yeah, so quality really matters. And all these things can be tied together, in the corporate sector, really, by tracking. So by modern tracking tools, you can, I mean, one of the bedrock for insurance back in the days, was that your insurance policy was supposed to reduce in premium every year if you put the right prevention programs on ground, right? But as we see, it just keeps ballooning. It's growing up because we are not paying premium to that preventive program. And unfortunately, corporate organizations think that once they pay for health insurance, everything should be done by the HMO or by the providers. So I paid for my health insurance for the year. I don't want to hear anything about any health screening. I don't want to hear about wellness program. Please go and cover it. That is so false. Occupational health and wellness are not health insurance. Let's understand that. It's not part of the package. You have to pay for that, separately. Otherwise, you have a workforce that in the next couple of years won't be resilient. They can't stand what is coming to the future. Right now, 1 out of every 3 Nigerians is hypertensive. 1 out of 3. Let us think. Right now, sudden death in Nigeria has risen to 30% of all chronic illnesses percentage. Is really an epidemic waiting to grow out. Even for the people that think they have money, that's the corporate sector. So we need to look at all these things and say, what, our health insurance policy must also, be qualitative in nature. The quality of what we get should not just be based on hospital care. Like I said, there's rehabilitative, there's palliative, and there's prevention, and there's health promotion, which is very, very key. Driving the message to the people on how to stay healthy, how to take care of yourself, self-care, plans and programs. Thankfully, we have health trackers nowadays. On your phone, on your wristwatch, you can track a lot of vitals about yourself, and these are key. To even help us saving cost, of hospital care.
Thank you so much, Dr. Abayomi. I know that one thing that you have spoken about passionately is how to get the information out there. how to get people to use digital options, digital tools, less interfacing with the healthcare facilities, more cost-effective ways to take responsibility, for their health. I don't know if that does justice to the summary of all of the information that you have shared out here today.
Yeah.
What I know that I have promised myself that I would leave this conversation with is a 1-minute summary from all of the subject matter experts here as to what strategies we can speak to, because we're hoping to develop policy statements from here, not just policy statements that are going to sit on the shelf, but actionable plans that we can take to communities to ensure that people are in a better position to demand healthcare and to demand health insurance by themselves, and for their families, because we held this conference in 2024. So I'm going to go to each panelist and seek your expert opinion on that strategy that you think that we need to be implementing that will change the lives of the people in the communities. I will start with Dr. Morris in 1 minute.
Right, Dr. Ann, thank you so much. So for me, is to lay emphasis on the public-private partnership conventional model, to move away from that model and introduce innovation, introduce creativity, but more importantly, introduce sustainability. And there is no sustainability without understanding the behaviors and appreciating and respecting the behaviors of the parties involved. I do strongly believe, and I say this with every boldness, that private sector needs to work more at understanding where the public sector is strong, is able to, what they bring into the solution, and work with that. It's like a marriage. That marriage does not exist if both parties don't respect one another. And I do believe, yes, sometimes the person with the upper hand, especially with money and funding, seems to believe that he has, a better perspective or a better place where he or she is coming from. But having said that, is to recognize that some of this base of the pyramid, sometimes, I mean, if you think about it, if you have domestic workers, if you insult them and you give them money, they won't take it, no matter how hungry they are. I've seen that happen over and over and over again. And I'm not saying that the public sector is poor. I'm just saying with the right attitude, with the attitude of sustainability and sustainable behaviors, we can move the needle in terms of ensuring that the demand is
good place to leave it, Dr. Atoki, as always. I would come over to Mrs. Ihekwazu, your 1-minute pitch for strategy that will increase demand.
All right, thank you, Dr. Ann. I would say I'll summarize it in 3 key points. 1, advocacy, 2, access, and 3, trust. So very quickly on advocacy, I think we've all understood and explained in many ways that there needs to be better education and advocacy to the public about the need for health insurance. And as Kenneth mentioned, there is a need to use existing platforms. I think most of you know the 14th of June was World Blood Donor Day, and Dr. Bayomi alluded to the need for preventative care. So when people go to donate blood, they also have a health check. That's an existing avenue to also talk about health insurance. So that's the advocacy and education. On the access part, if somebody wants to have health insurance, even if they understand, how do they even access it? There hasn't been enough done by the private sector, especially in going to where people are. So there needs to be a bigger move to go to where people are to ensure that they are able to access health insurance, be it public or whatever. So, going to marketplaces for the informal sector, going to, bank, wherever you need to go to where the people are. And third of all, trust. There is genuinely a lack of understanding in Nigerians about health insurance. A banker I know who has 17 years experience asked me, if I don't use my health insurance by the end of the year, do I get my money back? So there really is that gap in trust. So those are the 3 key points I'm going to summarize. So
we leave it advocacy, trust, and access. Over to Mr. Rotimi Olatunji, your 1-minute summary. Your mic is on mute.
Thank you, Dr. Ann. Dr. Morris, you know, if you insult people and give them money, I think this time around they will take it, but it doesn't change anything. So foremost, I'd like to start from economic revitalization. There is no strategy anywhere in the world that will work without improving people's lot economically. That's one. And then two, as alluded by Dr. Vivian, there's a huge deficit of trust. And so government needs to work more on the sincerity of purpose such that we can bridge the trust gap. Two, we need to deepen advocacy and organic engagement from experience. You see, largely, the informal sector in the health insurance space is still techie shy. The moment you begin to bring your phone and the rest, yes, of course, it brings efficiency and the rest of them. A class of that economy would accept that. You know, till date, some people don't even use their ATM cards, call it automatic.
So I hear economic revitalization. I hear deepen advocacy and organic engagement, and I would rest it with you, Mr. Rotimi Olatunji. Thank you for those words.
Thank you.
I would come over to Mr. Kenneth Okoli, and we will take 1 minute from you.
Thank you very much, Dr. Ann. I think the three prior speakers have actually touched on a lot of points. But one other thing I would just touch on is that we need to start finding solutions as to how to bring care closer to bring the providers of care closer to those who need the care. I've heard Mr. Rotimi talk about the booths that they're trying to create here and there, but we need to find ways to make that also attractive for the private players, because the government can't do everything. At the end of the day, after all said and done, one cannot take away the fact that the private players are in for business, of course, not to make a huge chunk of money, but it must be attractive to them. If it's not attractive to them, they will stay away. Okay, so in trying to ensure that the demand side pulls in, okay, those who are also creating the supply, it needs to be attractive, similarly attractive to them in some way, shape, or form, so that they are fully invested. Okay, and I would like to leave it at that. Okay. Thank you very much.
Thank you so much, Kenneth, for those words. And I would ask Dr. Abayomi for his 1 minute pitch.
Okay, thank you. So, I mean, for me, it's about democratizing, access to healthcare, in those communities through one, community participation, and obviously through private sector engagement. For example, we're working on a project in the DRC right now, where a private company, adopted 18 centers, primary healthcare centers, and we are working with them, to strengthen the health system, to garner community engagement, and to improve the health outcomes. And we could see the way the community that are reacting to those programs, coming out en masse, to accept and embrace those services. For me, that just does it. You have put the community conscience. This is available. We are here for you, and whatever you tell them, they seem to be doing. So through that, you can easily say, push your health insurance and initiatives to them. So I would leave it at that. It's about that community participation and driving private sector engagement to better.
Thank you very much, Dr. Abayomi. That's a good place to leave that conversation. Community engagement, advocacy, and ensuring that we are not talking about the people without the people, because many times we have challenges when the people do not take ownership for whatever plans we have rolled out for them, whatever investments that we make on their behalf. Most of the time, they consider it as other people's interests. We need to continually engage with the people if demand for health insurance would improve significantly so that we can achieve universal health coverage. So we do have a few questions from members of the audience, and maybe we can take it very briefly because we have another 10 minutes to close this expert panel. I want to thank you, distinguished panelists, for your succinct participation, for your expert opinion, and for how much knowledge you bring to the table. So one of the questions they have asked here, and I think this will be for Dr. Abayomi, will be, how can private sector health technology innovators access funding support? I do not, so I think, and then we talked about risk pooling. That was Dr. Atoki. How do we recommend or how do we mitigate against chronic disease prevalence and improve access to primary care? Then I also see what are the plans beyond holding conferences and webinars for alignment of public and private sector policies to achieve the desired outcome. I think Dr. Atoki would handle that. Then would including alternate traditional medicine in our healthcare improve people keying into health insurance? Mr. Rotimi Olatunji, you have been around in Lagos. You would know if this works or if this does not work. And then we have what is your adoption of telemedicine on virtual clinics as a means of easing healthcare? I think Mr. Abayomi. We will take a few more questions for the other panelists. And then, but in the meantime, could we, in a minute, address these questions?
Okay, I guess let me start. So, I mean, in terms of healthcare innovators, the funding pool available to us, because I'm also an innovator, maybe 3 or 4, so you have first, your regular bank loans, which I don't encourage for startups. Yeah, 1, 2, you have private equity investors, which may be one of the best ways, and you have angel investors. And you can also have, partners that share your dream, that want to partner with you and take over half of your business. So, but really, it's a change in the trend a bit from last year, as we have seen 3 years ago. The funding pool has gone down, actually. It's not in Nigeria, globally. Private equity investors are now more wary, because of the failure rate of startups, innovators. And that's because even for we startups, we don't do the homework very well, because we have these nice ideas, we think, can serve a market, but we don't know what the market wants. That's one of the biggest issues, why you won't see anybody to fund you if you don't have,
could we quickly address the second question about adoption of telemedicine or virtual clinics as a means of easing healthcare and affordability?
Yes, absolutely. So telemedicine, even though the adoption rate is still not very encouraging, because we don't market it, as we should. It should be in your face business. People have brought in a lot of solutions, even in rural communities. I've seen places where they hang satellites, funded by NGOs, and they talk to doctors abroad, but it's not being marketed. So it's already happening, virtual clinics where you don't have to even go anywhere. You see a doctor, you see a pharmacist, you see a lab person, and you go do your test, or they come take your test in your house. It's happening already. So that, it can work if we really push it, if it's on the forefront of our agenda as part of a complete health package, not just about health insurance alone, but using telemedicine to also cut costs and having more access to specialists. I believe it will increase the health outcomes. Yeah.
Thank you very much, Dr. Abayomi, for that response. Comprehensive indeed. I will quickly come over to Mr. Rotimi Olatunji to find out if introducing alternative or traditional medicine into our healthcare would improve people keying into health insurance. Do you have any data on that with your experience in the field?
Yes, I think it's an inevitable development that will happen shortly. The Lagos State government has a robust structure, a traditional medicine board that regulates the practice of traditional medicine in Lagos State. And it may also interest you that quite a substantial number of some of the medications are approved by NAFDAC. So the Lagos State Health Insurance Agency has opened a channel of discussion with this board. This discussion will soon be closed, and then it will open up an opportunity for us to empanel traditional medicine into our benefit package. That I can assure you, you start seeing shortly as part of the benefits that you can enjoy. So people have a choice. You want to go the orthodox way, or you want to go the traditional way. Thank you.
Okay, thank you so much, Mr. Rotimi Olatunji. So I'll come over to Dr. Atoki. In terms of how do you recommend that we mitigate against chronic disease prevalence, which is beginning to show up in our on our diagnostic template now, things that non-communicable diseases that were not a problem before are suddenly showing up, risk pooling and improving access to primary care. Thanks.
All right, so the question sounds like so when I hear risk pooling,
Yeah.
my mind goes, completely to areas around reinsurance.
Mm-hmm.
But again, addressing some of these new communicable diseases. So for me, really, it's and I'm glad people like Dr. Rotimi and Mr. Rotimi is here. You see, the government needs to be deliberate in the sense that your primary healthcare should be priority over some of these other areas of health. So in ensuring that they give a bit more priority to primary healthcare partnerships and solutions, a lot of the non-communicable diseases that actually will fit into some of these, healthcare solutions that a lot of beneficiaries will benefit from. In terms of non-communicable diseases, especially the cholera situation, and maybe even the pandemic that just left us, hopefully in quotes now, is to recognize that we're in a global community. Is to recognize that whatever happens at the base of the pyramid, has one way or the other of hitting us, no matter wherever we are in Lagos State or, in our confines in Ikoyi and all of that. Having said all of that is to take responsibility, government, private sector, international partners, and all of that. Not just take responsibility by ourselves, take responsibility when we engage one another in collaborative efforts to be able to be as result-oriented as possible in providing the solutions. The last one is on risk pooling, and that's the person who has questions actually spoke to. So the reason for risk pooling is to create reinsurance schemes that spreads financial risks. And this is largely associated with ensuring low-income populations for feasibility and for affordable premiums. That is essential. It doesn't happen when a community or a group of insurers are not collaborating. It requires a lot of collaboration. It requires trust. And some of these efforts require private companies working closely with governments, with NGOs, with community organizations to create that sustainable impact and insurance solutions that is required. Thank you very much.
Thank you so much, Dr. Atoke. As always, I would like to address this question to Kenneth Okoli in terms of what strategies or how can we use private sector investments to deliver poor development. A lot of people seem to be worried, about the cost of healthcare services, especially the diagnostic. I know you touched on it when you were speaking earlier on, but it's come up again, which means this is an area of concern, for many people who would like. So how do you think you can use private sector investments to reduce the cost of healthcare, thereby improving uptake of health insurance, especially in the area of diagnostics?
Thank you very much. I think it's even beyond diagnostics. I think it cuts across the entire healthcare value chain. But speaking to that, in fact, I saw the question, I was hoping I get to speak on it. So one thing that could be done, and it's a very simple idea, I think Dr. Ebere, the keynote speaker, the individual who gave the opening remark, touched on it a bit. There is, according to Dr. Leke, there is a huge gap with regards to recurrent expenditure. We need about 6 trillion naira annually. Okay. Now compare that to the $10 billion that the government needs to spend on infrastructure annually, at least for the next 10 to 20 years, to be able to bridge the gap that we have. It's definitely impossible. Okay, let me say it's close to impossible to have that right now. So the idea is this: how about the money the government would have spent on infrastructure or anything? The government keeps that money, okay, and says, okay, this pool of funds in Mushin local government, we have some money for you people to be able to access care with your contributions and all of that, and you are guaranteed access to care. Then we call private players and say, we don't want to build the infrastructure, but we can guarantee you huge uptake of maybe 60 patients a day, 70 patients a day. You build the infrastructure. The government regulates the prices, okay? We sit down with the government and we agree with the price that works for everybody. Okay, so nobody's cheating the other person. We use technology to monitor those who are coming to take up care or those who are coming to access care. At the end of the month or at the end of any period that we agree, the government pays the private players. Note, what makes it attractive to the private player is that he's guaranteed of uptake. No private player is going to go and invest where he's not guaranteed of uptake. Okay, but with government coming in and saying, I'm going to pay part of what is required by the people who are going to be requesting for care at an agreed tariff. So it's not as if you're not cheating people. There's a government agreed tariff. Okay, once that is done, people go into access care, of course, leveraging on Dr. Vivian, who has done the advocacy and all of that, leveraging on Dr. Abayomi's technology and all of that. You have people going to get the care, being delivered by the private player, paid by the government and other insurance companies who have agreed on tariffs set out by following a roundtable conversation or following certain agreements that have been reached. That is one way the private can work with the government to deliver quality care to the end users. And it's attractive to the private players because uptake is guaranteed. I hope that helps.
That definitely is helpful. And so I would like to ask Mrs. Ihekweazu now to see if you can just briefly touch on the strategies. I know this is the bread and butter for Nigerian Health Watch, and we could be here for the whole day if you were to bring your expertise to the table at the level. But just briefly to highlight some of the strategies that can be implemented to raise awareness about the National Health Insurance Scheme and educating the public on how to access health insurance. What strategies, top 3 that we could use that will be make the most impact?
Okay, thank you for that, Dr. Ann. I think, you know, the National Health Insurance Act, quite a long, complex document. The first part is actually breaking it down and using different platforms to help, first, actual people at the state level to understand how they can communicate that to people at the state level. And then the other audience, ordinary Nigerians. I think ordinary Nigerians is probably where the biggest gap is. I mean, we've talked about extensively that many Nigerians don't even understand what health insurance is. So what I would say that needs to be actively done, because I think this is one of the big mandates that the new DG of NHIA is pushing, to push up enrollments. How else do we push up enrollments if we do not have focused advocacy campaigns using the multiple platforms that people engage on, be it radio, TV, print, whatever, but especially not forgetting the vulnerable group? Where are we ultimately going to find them? Wherever they are, that's where we need to get to. So using community engagement, mobilizing other institutions. We talk about health insurance because it says health, and that's the purview of the health sector. It's not. It needs to be a multi-sectoral approach, national orientation agency, leveraging all existing ministries, departments, agencies. Where in the work that they do, can they find that avenue to explain to Nigerians where health insurance is, what health insurance is? So ultimately, I think it really needs to be a multi-sectoral approach and ultimately go to where people are and help people understand what health insurance is and the financial benefit of actually being insured as opposed to what people are spending right now out of pocket. Over.
Thank you so much, Mrs. Ihekweazu. Always a pleasure to have you talk about health advocacy, health awareness, health promotion, and all of the expertise that comes with Nigerian Health Watch. So this morning we have been talking about the role of the private sector in achieving universal health coverage. We've looked at enhancing accessibility and affordability. We have looked at innovative strategies for inclusion. We have looked at policy frameworks and regulatory support. We have looked at community engagement and building trust with these seasoned panelists that we have here. I bring you apologies from Mr. Ikechukwu Ofuani, who had an emergency meeting with one of the state governors and was unable to join the panel. Ladies and gentlemen, I want to thank you for keeping faith with us this morning in the past hour. I would like to sincerely thank the distinguished panelists for their expertise, for their contributions, and for their very knowledgeable conversation that we have had this morning. It's been my pleasure moderating this panel and being a part of this conversation. Thank you so much for being here, and do have a good morning, everyone.
Thank you, Dr. Ann. Thank you all.
Thank you so
Have
much, Dr.
morning.
Ann. And thank you, esteemed panelists, for sharing insights as to how the private sector can drive universal health coverage in Nigeria. I think it's a topical conversation, and I'm glad it's happening at this time. So next on our agenda, we would have a keynote presentation from day one that was presented by Dr. Tayo Adulodu, who is the CEO of Nigerian Economic Summit Group. We understand that it's important to see or to hear what was discussed 2 days ago as is part of the conference, and how that can also throw more light on our conversations today. So it's a 15-minute long video, but I'm sure that we would definitely have something to take away from it. Thank you.
Ladies and gentlemen, it's a pleasure to be in the company of very distinguished experts. PSHAN, I think, is a pride of us all, a necessary vehicle at a time of significant climatic shifts in our country. I think COVID sent us some clear memos as a people. One of those memos is that if we all wait for the public sector to plan our future, we might be in for a rude shock. I was private sector advisor to the Presidential Committee on COVID-19 response. And I remember the first meeting on day one as COVID broke out around the world. And the shocking reality that health systems readiness was almost zero, and that what we considered as being safe was hope. Hope is not a strategy. I remember asking questions that almost drove me mad. Questions that included how many beds are ready, which labs are good to go, how many labs can be upgraded to COVID-19 testing requirements, and then the answers are coming back. I think I got on the phone with Ahmed, Ike, and a few of the other captains of the industry and said, look, we better jump in and just do our work if you're going to save Nigeria. And I think for me, that experience reflected what will happen sooner or later if private sector does not lead. It's going to collapse. And I think if everyone forgets that that's where we were with COVID and goes back into business as usual, it means truly national amnesia is a disease. We are devastatingly behind on practically all global health outcome indicators, which means if you do not scale up response you deploy collective capacity of the public, private sector, civil society, we will not truly make any progress. And not making progress is painfully an alternative that we cannot actually wait to see. This is for 3 or 4 reasons. One is, of course, we know it's a human right. But health as a human right means nothing if the capabilities to pursue that right do not exist. What is the comprehensive national financing framework that is optimal to get us to where we need to go, and how much of it can be carried by paying private sector or citizens who can afford private insurance, and how much of it is really vulnerable populations that cannot be carried by private insurance and need to go elsewhere? Why is this critical? Nigeria is still a country with 133 multidimensionally poor people, of whom 127 million are health poor. 127 million health poor. So when we have this universal coverage conversation, there is a big conversation of how you allocate those resources for affordability. Affordability becomes a big word, especially when you're dealing with people who can't afford it. The question as to affordability versus accessibility is not well debated, because automatically it puts a certain amount as subsidy, both for the private sector and for public health institutions. So we kind of have to have a conversation of what is the national health financing framework, how much of it will be allocated by government, and how much of it will be an investment, how much of it will create affordability because of a subsidy, and how much of it can be paid by, in the lifetime of a worker or a citizen who can afford to pay. This is also poorly understood, and this is one of the things we said to our dear brother who is a brilliant health expert and has resumed at the NHIA, that you need to pay attention to the size of the problem and then to the part of the problem you can solve, and bring all of us in to the part you cannot solve, and not try to do everything and crowd us out. So that's something that we think is very important on the affordability. So one of the things we've said to our public colleagues is, let's build something together. You know, yours has failed, ours worked, but ours is disjointed, right? Because the private sector does not have one private sector health referral system. So can we build something outside yours and ours together and integrate it into a whole? And the technologies are now available, right? Between blockchain technology and platforms like Farm Access has deployed already. This is not rocket science. This is doable tomorrow morning if we agree that we're going to get going to do it. So I think a big part of making this work is you can't have the payment system without the databases and the data sets of citizens and the paying or using healthcare markets pulled together. Healthcare markets is a big word, and we need to start to use that word, because Nigeria grew up on free healthcare for all. Mismanagement of oil, we are in a big fiscal deficit. Free healthcare for all is impossible. 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 What is possible to us is affordable healthcare. And affordable healthcare is possible to all of us in Nigeria if we kind of do things differently. So I'm a big supporter of the Vulnerability Fund, and Minister Pate knows he has our support in it. But I have said we need another big pool of money that is not a vulnerability fund, that is a private sector financing fund, that is built with the intentionality to do some of the things that the Health Federation of Nigeria has asked for. The last part is the set of financing tools that must serve where. I think one of the, and thanks to the chairman, Mr. Jim Ovia, and the other corporate partners, Alhaji Aliko Dangote and Ike Imokode, for what they've done, especially in shaping a corporate-led approach. Now, that approach is crucial for three things. One, not all type of credit, or not all types of finance is useful for all parts of the health supply chain. And so we think that the philanthropic investments that need to go into the parts that are not bankable, they're not profitable, need to be well defined. So it's like Mokode and I had a conversation a couple of years ago. I said, look, there's a size of philanthropic investment needed every year in healthcare. We need to simply raise the money and put it there, and stop having conversations about affordability, because they can't afford it. Now, what is that size? That size should be a target for philanthropic leaders in Nigeria to simply meet every year without fail. And we can. We see the money, going to the parties on those exotic islands. A few $1 million more could move elsewhere to support those kind of initiatives, and that's important. Now, the second type of money we would like to see is impact investment money. And this money, we don't want it to be free. We want it to drive innovation and products that change the numbers on ground. So, for example, the kind of impact investments that went into ending polio in Nigeria was transformative. And all of us saw the transformative effect of well-targeted impact investments targeted at reducing both increasing data, increasing intelligence, access, surveillance, drug and access and delivery, training, you know, and the feedback mechanism that allowed us to push polio to, you know, its final stages of being an old historic experience in our natural. But that's what impact investment does. And again, we need to scale the impact investment piece, because there's a lot of impact that needs to be created across so many areas that, again, it's not MPR price money from commercial banks that can do it. And so the second challenge that I have made to private sector leaders is to scale the impact investment component. I've actually said to our sister Maria at the Impact Investment Foundation that we need to think about how to pull targeted investments into where it makes the largest amount of difference. Then when we come into the social investments and traditional investments, three things are crucial. One is that we need enough partnerships with the commercial banks to decide what is bankable, you know, in terms of infrastructure, and whether it is better to do health infrastructure through commercial banks or DFIs. No, so I think with strategic purchasing, it goes down to types of money chasing, the types of supply components in the supply side. Now, how do we ensure we are keeping the whole generation of students in the medical field going through the system without the worry of how to pay tuition, etc., etc.? The last thing in thinking about a post-pandemic Nigeria is how we buy anything. But the second part of that is how to buy production capabilities at home that work here. And so we've been around the world in the last few months discussing with specific investors. We have a huge, it seems, opportunity coming out of the EU potentially to invest in some of those value chains. But that's important. Strategic purchasing across the sector has to be comprehensive, well thought through, but it has to be done not government-led, you know, but private sector-led to be sustainable, and government as an enabler. For now, there's too much of government must lead, and that has its, of course, its own problems in a country like ours. So at the end, the NIA and its benefit packages will work to the degree to which the institute authority is efficient. I think there are opportunities there, but I think accessibility will come from a broader, more collaborative approach. One thing to remember, and I don't think this is a message for us, but for our public sector side more, is that partnerships do work. You know, if it didn't work, we wouldn't have expanded loot during the COVID, we wouldn't have expanded loot, we wouldn't have scaled up testing. You know, it works because it works generally when we make it work and when we agree that we can't do it alone. And so I think we should go back to think about we should simulate a COVID crisis level urgency, and maybe that helps, because the critical infrastructure investments have slowed down and that needs to scale. But we need sanctity of contracts. So one of the problems with PPP infrastructure is the sanctity of contracts. Can we start something with the state government and come back in 8 years when there's a new government and nobody simply just pulls the carpet off your feet? We have this littered across many states in Nigeria. We have some of us, you know, invested in the whole ambulance support services for government, and new government basically went to buy a whole new set of ambulances and just unplugged you, and you're stuck with 20, 30 ambulances. So a big part of PPPs is maybe we sit with ICRC, the concessioning partner of government, and agree, for example, on sanctity of contracts. There has to be an entity that allows us to hold government accountable to the longer term contracts. We've built some wonderful block of empty hospitals that by the time we were ready to resource them, the government changed and the hospitals were left as carcasses. Because the new governor comes in and he's not a friend of the old governor, and our credit is stuck, our investments are stuck, our credibility goes down the drain. And so some of these are crucial, but all these will not work without sanctity of contracts. PPPs in Nigeria, particularly in the health sector, has been most significantly impacted by that. I think there's a lot of opportunity for capacity building as PPPs. Our government colleagues, because of whatever the reasons, are not scaling in terms of know-how as fast as the private sector. We think there are ways to solve that through a public-private sector exchange model, and that's something that could also be an opportunity. Okay, amongst mint nations, right? Look at Nigeria, notice how they correlate. Universal coverage and life expectancy, positive, and almost perfectly, right? Yeah. Well, no, but these are the numbers. Yeah, but yeah, these are the numbers. And so, in closing, ladies and gentlemen, whilst we push for some of these interventions to happen, health is a sector. Health is an economic sector. We need to build back, on track. We need to move the systems forward. But a huge part of making that happen in Nigeria will be about getting together, co-creating together, and more importantly, putting on the table that health sector is not just a social sector, it's an economic sector. It needs its factors of production to be protected and supported in such a way that we scale for both productivity and impact. Thank you, ladies and gentlemen, for listening, and wishing everyone a great celebration.
Hello, everyone. So thank you so much for staying up to this time. I know we've a bit of your time this morning. So we'll just play a highlight video from the Leaders Summit that we had 2 days ago, which was on Tuesday, the day one of the conference. Thank you.
It is a great honor to welcome you to the 2024 PSHAN Annual Conference with the theme, Harnessing Private Sector Solutions for Universal Health Coverage in Nigeria's Evolving Health Insurance Landscape.
So as the public health need emerges, we have a strategic plan that responds directly to those needs in a holistic manner.
That you need to pay attention to the size of the problem and then to the part of the problem you can solve, and bring all of us in to the part you cannot solve, and not try to do everything and crowd us out.
These hospitals actually operating. From our own work in Farm Access, we have seen in Kwara State and in Lagos State, some of our work, that if you do these strategic purchasing contracts, you can actually improve the situation to a certain degree, but recognizing it's not enough. And if you're a private hospital, and we are here about private healthcare facilities, you struggle to access the financial investments that are needed to invest in your hospitals, to expand our services or improve the quality of care. So all of this is resulting in this vicious cycle of demand and supply, where people don't trust the system because every time they go to a facility they see that it's not working, but because nobody is prepaying, including those who can pay, so an increase of resources, we're stuck in this virtual.
They made me understand that they've been able to cover over 300,000 vulnerable people in Lagos State via the Equal Social Health Alliance.
That's the point that I'm trying to make. We haven't failed. We're on this journey, and that data-driven decision making is what we're lacking.
They can get cost reductions seems to favor the sustainability of health insurance.
So that means for the next 20 or so years, adequate platform to capture so many things going on, so many fields of data, age, sex.
So we pick the ones that work for us in our space and run with them, and also build on them, so that we can actually have a Nigerian-owned health insurance system. What works in the UK or America or indeed Ghana, Togo, may not necessarily work for Nigeria. We need to have a homegrown one.
The countries that have run public health insurance have struggled. We know what's happening in the NHS. She says more than 50% of their providers are private. The private sector does come with a lot of competencies, and the role of the NHIA should be regulation.
I conclude by saying that we must all embark on this transformative journey. We must also remain committed to ensuring that every Nigerian has access to quality healthcare.
As we move forward, let us carry the momentum of today's discussions into our daily work. Let us continue to forge strong public-private partnerships, invest in cutting-edge technologies, and implement best practices that will drive sustainable progress in our health sector. Thank you very much for staying tuned with us. We are getting close to the end of the web conference today, and would like to especially thank everyone for joining in, for staying with us, for listening to the conversations, and also sharing your thoughts and comments as well, and questions. The beginning of our conversation today has been how the private sector can drive universal health coverage in Nigeria. And I do strongly believe that our conversations today, shows us that every hand must be on the deck, from the policy makers down to private sector stakeholders, and everyone within that value chain to be on the same table to drive action to achieve universal health coverage. So to give the closing remark for today's session, I'd like to invite Mr. Christopher Awanting, who is the head of Enterprise Resource Management, Private Sector Health Alliance of Nigeria. Thank you.
Okay, thank you very much, Clifford. Good morning, distinguished guests, esteemed speakers and delegates, ladies and gentlemen. As we conclude the 2024 Annual PSHAN Conference, I would like to extend my deepest gratitude to each and every one of you. Over the past 2 days, we have witnessed insightful discussions, innovative ideas, and invaluable networking opportunities. Our team, Harnessing Private Sector Solutions for Universal Health Coverage in Nigeria's Evolving Health Insurance Landscape, has not only sparked meaningful conversations, but has also set the stage for actionable strategies and partnerships. As we strive to process the achieving of universal health coverage through the health insurance system in Nigeria, the contribution from our esteemed speakers, panelists, and participants have been instrumental in shaping the future of the health insurance system in Nigeria. As we leave here today, let us carry forward the momentum and commitment made during this conference. Let's continue to collaborate, innovate, and strive towards expanding the health insurance coverage in Nigeria, especially to the underserved communities and the marginalized groups, as outlined in the Nigerian Health Insurance Act. Together, we have the power to make lasting impact. I encourage you all to stay connected, follow up on conversations, and explore new avenues for collaborations. Remember, our journey towards achieving universal health coverage through the health insurance system in Nigeria is ongoing, and it requires sustained efforts and dedication from each of us. On behalf of the Private Sector Health Alliance of Nigeria, Thank you once again for your participation, enthusiasm, and commitment towards the advancement of positive health outcomes in Nigeria. Wishing you all a beautiful day as we look forward to seeing you again next year. Thank you and God bless.
Supporting serious private sector interventions. And two examples come to mind. We've heard one already, which is the Adopt a Primary Health Facility Program, pioneered by Mr. Aigimokwede's ABC Health, in collaboration with Private Sector Health Alliance of Nigeria, which was also founded again by Aliko Dangote, Mr. Aigimokwede, and Jimovia. Their goal, as we've heard, is to establish a chain of primary healthcare centers across Nigeria in all of the 774 local government areas and apply market-based reforms to provide low-cost health services at decent standards for the poor and the vulnerable.
At the Adopted Healthcare Facility Program, we aim to revitalize healthcare across every point of the pipeline, as from renovating the health facility, providing water to the community, providing drugs, affordable quality drugs, providing healthcare insurance, providing affordable care to the community. The Adopted Healthcare Facility Program is a program, a flagship program of PSHAN, that is aimed at revitalizing one primary healthcare center in every local government in Nigeria. This is aimed at improving healthcare outcomes, maternal and childhood health, and overall improving the health of the locals at the grassroots.
We launched ADHFP last November in Lagos and saw how PSHAN piloted the initiative in Delta and in Bauchi by refurbishing and bringing up to standard two very dilapidated structures. These two facilities are now equipped with essential resources, medicines, potable water, power and medical equipment, and essential workers are now being supplied through the state and through other private means to support these two primary healthcare centers. As we roll this out, we welcome all of you, whether individuals, corporates, families, groups, to join us as we try to revolutionize the primary healthcare center one facility at a time.